Patients and doctors should be making the big decisions, not government bureaucrats. Step by step. This is what our plan to repeal and replace Obamacare will do.
But the important thing is to make sure the people who are now covered are not left behind.
This is something that literally affects people's lives and their livelihoods, so it's not something we can rush.
They will have plans that today nobody has even thought about, because the market's going to enforce that with millions and millions of people wanting health care.
Let's all pay a fair share so that everyone can be covered.
This is the worst thing that ever happened to the American consumer.
Thanks so much for being with us tonight for our digital discussion on healthcare. I'm Allie Bradley.
And I'm Jackie DeTore. Tonight we are going to offer you, our Facebook followers, an opportunity to ask a panel of experts your questions on this important issue.
All you have to do is post your questions relating to healthcare in our comments section. We will be picking them at random.
So let's take a look at how we got here. During his run for the White House, President Donald Trump stated his intention to repeal and replace the Affordable Care Act. After winning the election and taking office, he immediately pushed to make it happen. House Republicans put together a proposed plan calling it the American Health Care Act. In March, the U.S. House withdrew that plan from the floor, saying it didn't have enough votes to pass. Then, despite not having enough votes again last week to put a bill on the House floor, the White House expressed confidence today on the ability to pass a health care bill before going home for recess on Thursday. And President Trump expressed the same over the weekend during his 100-day rally in Harrisburg.
We're going to get the premiums down. We're going to get the deductibles way down. We're going to take care of every single need you're going to want to have taken care of, but it's not going to cost that kind of money. We're going to give Americans the freedom to purchase the health care plans they want, not the health care forced on them by the government.
Now, despite confidence, the Republican Party still lacks the 216 votes needed to pass a new health care bill. Republicans say they refuse to move forward unless those votes are secured.
And we're going to start our digital discussion by introducing you to our panel of experts. Andy Carter is president and CEO of the Hospital and Health Care System Association of Pennsylvania, He represents nearly 240 acute and specialty care hospitals and health systems across the state. Prior to that, Mr. Carter served for nearly 6 years as the president and CEO of the Visiting Nurses Association of America, which is the national voice for nonprofit community-based home health and hospice agencies. Russell McDade, he is the president and CEO of the Pennsylvania Healthcare Association. Thanks so much for being with us as well. It represents more than 500 for-profit and nonprofit senior care and service providers. Prior to this, McDade spent almost 10 years as a vice president and chief policy officer for Leading Age PA, which represents nonprofit senior service providers. He was also chosen by Governor Tom Corbett to serve on his transition team for the Department of Aging, Public Welfare, and Health.
So let's get to the questions and the discussion. We'll begin with you, Andy. Sure. Obviously, this has been a debate going on in Washington, D.C. for not months, but years. So first and foremost, why is healthcare such an important topic, and why should we care about it?
Well, we all need to be healthy, and we all count on the healthcare system to keep us that way. So it's very important to us personally. And it's also important because it's expensive, and it's been expensive for a long time, and as a result, too many people just couldn't afford insurance. And that's what the Affordable Care Act has been about. And right now we're in the midst of a very tough conversation about how to pay for it. And I think people are being fair on both sides of the aisle, trying to figure out the most efficient way to pay for it. And we all want to pay as little as possible. That's why it's so important.
Of course. And Russ, anything to add to that?
No, we see the same thing, in my world representing seniors and people living with disabilities who need round-the-clock care. That comes at a very high price, and the expectation is that the high-quality care will be there for you when you need it, but many people can't pay the freight that takes to provide that care on a 24/7 basis.
So let's talk about here in Pennsylvania. What do you think some of the biggest issues relating to health care are in our state?
I'd start with coverage. We have to make sure that people have affordable health care coverage. Without it, they don't get the care they need, and they delay it. They don't get preventive care. Basic conditions can grow into really dangerous and even fatal conditions if they don't get that care. So coverage has been the #1 priority since we began this conversation. And we made big strides here in Pennsylvania over the last several years. 1.1 million people now have coverage thanks to the Affordable Care Act. So that's a huge step forward.
We do have a question coming in here from Facebook. Robert is asking, as a physician, it is my opinion that healthcare is a right that should be afforded to all citizens of the U.S. What are the panelists' thoughts on a single-payer system?
Well, I'd say the charms of a single-payer system are easy to embrace. The problem with the single-payer system is that you have a single entity that's trying to manage an enormously big system. And the hospital industry has urged policymakers to recognize that a great deal of strength in the system comes from choice and from competition. And both of those qualities really are enhanced by having multiple insurance players in the marketplace. Government is certainly an important part of the delivery system. I don't think having a single payer is the most important next step we should be taking. We should first get the job done with coverage, and then we can move from there after that.
Can you break down the single payer system a little bit more for anyone watching at home that doesn't know what that is at all? That's maybe foreign.
Right. Well, and I would add, single payer system would mean government providing the vast majority of the health care in the country rather than private insurance carriers through an employer or through other sources. With our seniors and people living with disabilities, the folks that my folks care for the greatest degree, we have a de facto single payer system now. It's the state and federal government. So between the federal Medicare program, which picks up 15 to 20% of the cost of care for people residing in long-term care facilities, and then the state federal Medicaid program, which picks up almost 2/3 of the cost of that care. Government is the payer in long-term care for over 80% of the care provided nationally, and that's why we see budgets at the state and federal level strained so much. Now, your question on what are the biggest challenges facing our healthcare system, one of them is the fact that we're getting older as a society, that we have the baby boom coming up through the system, that we're going to double the number of 85-year-olds in our country in the next 30 years, and that comes with a hefty price tag.
Okay, so speaking on that, what do you think that the biggest issue right now, Russ, would be that seniors are facing with these healthcare changes or potential changes?
Yeah, with the Affordable Care Act, I mean, we've kind of had a tenuous relationship with the Affordable Care Act, to be quite frank, with our folks, because it's like squeezing the proverbial balloon. It did a lot of good for a lot of people, but you can't provide tens of millions of new people with coverage without those dollars coming from someplace. It was not a zero-sum game. And Medicare reimbursement for some of the long-term and post-acute care was one of the places that suffered a little over the last 3 to 4 years since the enactment of the Act. So it's unfortunately with healthcare not ever as simple as, I will give this group of people more coverage without a consequence someplace else. Now, maybe a consequence we're all willing to, accept, to provide care for folks. But there's always a consequence someplace else in the system.
To follow up on that point, Russ, we agreed as a hospital community to give up payments that the federal government was planning to send to hospitals over the next decade. And we did that because we wanted to help finance the expanded coverage that people wanted to achieve. And that's why this conversation now about repeal and replace is so worrisome, because the conversation is about reducing resources, reducing rates of coverage across America. The American Health Care Act would lead to 24 million people losing coverage, but the money isn't being restored to providers who would then be on the hook to provide lots more free care and uncompensated care.
So I guess the question is, obviously this is being debated every single day. And from your point of view at the hospitals, what would you say was the best part of the Affordable Care Act? And what would you say to the lawmakers that moving forward, if repealing and replacing to changing to something else, what do you want in that plan?
I want a plan that maintains that coverage, because with coverage, everything can work more rationally. Instead of people wandering through the system, hoping to get episodic free care, and us taking care of folks who don't have the ability to pay. So starting with coverage is number one job for repeal and replace.
So with the Trump policy that he's kind of looking at right now, he's looking at the individual mandate that right now everyone is covered because everyone pays into it, right? And if you don't, then you get taxed on it later on. So the Trump plan, what we're looking at right now today, kind of looks at getting rid of that individual mandate. So both, you would say you're against that part of the policy.
Whether you have an individual mandate or you come up with incentives that make it really attractive to have coverage, we're open to that discussion. So either way can work. What won't work is trying to get all this coverage done and spend so much less on the system. The math doesn't add up. And the American Health Care Act takes out, in Medicaid alone, which is a big part of how we've expanded coverage, across the nation, it takes out over $880 billion. And that's money that's going to come out of the system, and the system can't do its job without those resources.
So what would you say to people, like you said, with a lot of the people you work with, that some of the issues, the same question I had to him before, that you like now, but something that you would like to see changed moving forward if there was a new plan?
Yeah, one of the challenges we're going to have with the new plan is they're working on something called a block grant. And if we all thought that single payer was confusing, block grant is incredibly confusing. It's essentially, right now, long-term care is an entitlement under the Medicaid program, and if another person enrolls, they qualify for that funding. A block grant would say there's a finite amount of funds, and no matter how many people come to the table, you still have to live within that finite pot of money. That is one of the biggest challenges that we would face as a society, because the vast majority of that care, as I noted, is provided under Medicaid, which most of us think is the low-income health insurance for low-income families who aren't able to buy it, purchase it themselves, or don't have an employer. It's actually also the largest payer of long-term care, as I noted.
So we have sorry, Jackie, we have a couple of people that are kind of commenting about Canada's healthcare position and how, it's vastly different from what we do in the U.S., but they're talking about how they have people that live there and they never complain about getting treated. They have, people that are in Canada that say that the system there is great. So break that down a little bit, because obviously there are faults. So let's talk about that a little bit.
Well, I think the important thing to do for any healthcare system, whether it's single payer, like is generally what happens in places like Canada, or a more free market system like we have here, let's just be prepared to measure whether it's delivering on what it's supposed to. Like the quality of care. If you go in for a procedure, you expect to get it done correctly. You expect to not have to go back to the hospital to have it fixed. And we can count those incidents. We can hold ourselves accountable for doing what people are paying for. And I think if we do a better job in the delivery system, being transparent with how we're doing, how many people in this particular hospital had their hip replaced without a problem. Tell everybody those numbers, people can judge the system. And that's one of the things the Affordable Care Act does. It encourages providers like my hospital members to be as transparent as possible as they can. We report data to the state to tell them how we're doing on procedures and the quality of care. That's going to allow all Pennsylvanians to judge whether they're getting their money's worth for the system.
And do you think for seniors in Canada that they're dealing with kind of a similar thing, because they're dealing with it from the bottom up, whereas a lot of people in our country don't deal with it until they are a senior?
Yeah, and I think one of the things we all have to realize when we look at other countries' systems is our expectations are sometimes different here. So the Canadians value their system, and they find that to work for them. They grew up in it. They always understood that it might take 5 days if you've got the flu to see your PCP, or you can go to a clinic if you're really sick. It'll take on average 2 weeks, let's say, for some type of an image. It'll take 3 weeks for a higher level procedure. You know, here in the United States healthcare system, those of us who have employer-based coverage or private insurance coverage rarely wait more than 24 hours right now for those intensive types of services. In every town around us, York, Lancaster, Lebanon, Harrisburg, there are enough imaging centers that if you go to the doctor and they say, you tweaked your knee running and oh, we need to get a picture of that, it's rare that you don't get that picture taken within 24 hours. And I don't believe that's the case in other countries' systems. But there are trade-offs, as with anything, and those systems aren't as costly to the consumer oftentimes as ours can be.
So speaking of costly to the consumers, what are physicians doing to try to get those costs down for consumers, and what can patients do to kind of keep those costs down for themselves?
It's a great question. It starts with having access to information. For example, at my organization, our website, there is a tool you can go in, Care and PA, and you can poke around and see what you might find yourself spending for a doctor's visit or a hospital visit, while at the same time finding out how good, on average, the quality of care might be based on data reported. So information is very powerful at helping to control costs. And I know it works because in the last several years, the rate of growth in healthcare costs has actually declined. And we have made huge strides in containing costs. One way we do that is avoiding these repeat visits back to a doctor's office or to a hospital for a preventable problem. So that's a huge way to reduce costs. I think also the fact that the Affordable Care Act does, across the board, ask people who can afford to pay for more of their costs, we are having them do that. And they have, as people like to say, skin in the game. And by so doing, they're asking more questions of their physicians and nurses to say, do I really need that test? Is that x-ray going to give me exposure to radiation that I don't really need? Plus I have to pay more for it than I used to. Those conversations help lower costs.
And the other significant change that we've seen is a shift in the incentives so that physicians and providers will actually get a better level of reimbursement if they provide care smarter, not providing more care. And there's a healthcare buzzword, value-based purchasing. What that essentially means is we're going to provide the best practice protocol of services, but it's no longer going to be whatever the consumer wants, drive me all the way up through the continuum. Volume doesn't indicate a better outcome necessarily, and that lets us be more efficient with our dollars as well.
All right, so I think we're on a really good topic here. A lot of people like to talk about the money when it comes to all this stuff. And I think you also touched on it too, the education. So we're going to take a quick break, and then we come back, we're going to continue our digital discussion on healthcare.
Patients and doctors should be making the big decisions, not government bureaucrats. Step by step. This is what our plan to repeal and replace Obamacare will do.
But the important thing is to make sure the people who are now covered are not left behind.
This is something that literally affects people's lives and their livelihoods, so it's not something we can rush.
They will have plans that today nobody has even thought about, because the market's going to enforce that with millions and millions of people wanting health care.
let's all pay a fair share so that everyone can be covered.
This is the worst thing that ever happened to the American consumer.
And if you're just now joining us, we're live on Facebook for an exclusive digital discussion on healthcare. We're taking your questions from our comment section and asking our panel of experts for some answers. Thanks so much for being with us tonight, guys. We have Andy and Russ here, some healthcare experts, talking about some pretty important topics. First, we left off talking about some of the costly impacts of healthcare.
And we just had a Facebook question from, I believe it was Brandon, who was asking kind of a generic one, but maybe you can break it down for us. Why do some people pay less and why do some people pay more?
The smiles on their face.
Let me see how we're jumping for that one. Yeah.
You know, there's a wide range of what people want to buy. That starts with it. Under the Affordable Care Act exchanges, for example, you can buy platinum, gold, silver, and copper plans. They have different levels of benefits and different amounts that you have to pay out of your own pocket. So that's one. It depends on, do you want to buy the top of the line plan and have less exposure for later costs, for co-payments and deductibles? Or do you want to get the skinniest plan possible and take the chance that you might have to pour out more out of your pocket later? So that's one reason why they pay different amounts. I think another reason would be that they have, as you mentioned earlier, different expectations for what they want from healthcare. Some people just want to go to a procedure at a particular place. They like it. They may not do the research to find out if that's the least expensive place to get that procedure done. That's where research can come in handy. So it's true, not every hospital charges the exact same amount for the same procedure. There are a lot of variables that drive that. So there's a couple of reasons. There must be others too.
Yeah,
well, I guess the question, just to follow up on yours, if Allie and I have the same condition, we go to the same hospital and get the same thing done, and we also have the same insurance and same deductible, is our bill going to be the same?
To your viewers, I don't want to give a definitive answer, but based on exact same insurance, same procedure, and if the procedure goes according to plan, because your healthcare conditions are virtually identical and there's no surprise bad outcome that may arise because of differences in you clinically, then you should have roughly the same cost. But you're human beings and you're not going to be identical. A procedure might last 20% longer. You may need more anesthesia than the other patient. All those things can change. But everything being equal at the same hospital, same clinical team, and same insurance, you should feel pretty good. You're going to have roughly the same cost.
Do you have anything to add to that, Russ?
I think what you're getting at, I mean, if you turn that 25 degrees to the side, and you don't have the same insurance, but it is the same procedure. We've all found ourselves, and I shopped on Andy's site that he mentioned for a procedure, and there was wide variation in my small healthcare market, and there was not a positive correlation between the outcomes and the price. So the highest cost procedure in the area didn't actually have the best outcomes. The best outcomes actually happened to be one of the lower cost services, and unfortunately that's one of the challenges with our healthcare system. There isn't a direct correlation. If the four of us were going to buy a car off the lot after we left here today, we wouldn't come with different expectations of how much we were going to pay for the car necessarily. Because of the insurance rules that different insurers have, particularly in acute care. In my land, in long-term and post-acute care, that's almost a direct, you get what you pay for. To Andy's point, you know, if you have a desire for a higher-end location, you have a desire for some place that also happens to have an in-house Olympic-sized pool for you to exercise in every day, and a fitness room and those type of things, you're going to pay significantly more a day than if you're going to some place that still meets a robust level of skilled care need, but it doesn't have a lot of the extras that cost more money.
So now are more facilities and more healthcare systems going in the direction of yours, Andy, where they're being a little bit more transparent with the cost? Because I know, not to break HIPAA violations, but we've both gone to the doctor this year and we're kind of surprised by the cost of what we had to undergo, and there was nowhere to find that information out, and there was no real breakdown on your bill. You just get, there's a bill, and it's pretty hefty.
Billing is got to go a long way before all of us can understand them. And actually, my members are taking a pledge to work with consumers to have much simpler billing systems. That's number one, so that a layperson can look at it and see what in the world just happened. Second, transparency will help. And we're doing that by, for example, not only is our website at the association helping, but some of our members have price tools right on their website. And you can tell them you're going in, that your doctor ordered this procedure, and you can get a pretty good estimate of what, and you tell them what your insurance is. That website can tell you what your likely out-of-pocket costs are going to be. And more hospitals are adopting that technology.
And do you think that's just something that people don't have that education? I know when I go somewhere and they'll be like, oh, you haven't done this in a few years. And I always say, well, how much will it cost me? That's not my first. And do you think that's what's scary, is that more people are concerned about what it will cost me as opposed to what is that test going to help me?
It's important to talk to your physician, because an honest, open conversation with a physician where you admit that you have some anxiety about the cost, but that you want to make sure you're taking good care of yourself, physicians will work with you to help counsel you basically on the importance of the procedure or the test, and they will help you make a decision about whether you can find the cheapest place but still safe place to get the test. Physicians are also learning how, and their office staffs are learning how to have those conversations with patients that they never used to have. So we have some skills to build up, no question about it.
And would you say the same for like the people you deal with? Because maybe they don't understand it as well as everyone else. I mean, the seniors, they have so much going on. They've lived a whole life. Right. Should they have to educate themselves on this now?
Well, they absolutely should. And we actually see the opposite. We see people showing up with far less information than we thought they'd have. And I think part of it is that natural kind of denial of something that's painful and difficult to deal with. On Andy's side of the healthcare system, it's about getting better, getting fixed, going to therapy, and getting back at whatever your activity is. On the long-term care side, people fear that it means something else, that it means that I'm never going to be back to what I was, that I'm never going to be able to play doubles tennis in the morning anymore, or whatever that case might be. And so they seem to wait until the very end, until that need arises, and then not be equipped with the information they need when an acute illness arises and they got to make a decision with a snap judgment.
You know, we have a program with the libraries across the Commonwealth to encourage people to learn how to have these conversations with their caregivers. Training on how you start a conversation, how you take notes, how you should bring a friend if you're very anxious. And that's, over time, is going to improve the quality of care, because unless you and I are actively involved in our care, there's no hope of getting the best possible results.
Do you think that's possible, though? Because I know for people like you, it's your full-time job to understand this. For people like us, it's basically only, like you said, when something goes wrong. So do you think that's actually going to be possible, that we will understand it more moving forward?
Consumers are demanding that we get better at it. You have choices. Procedures that you used to have to go to a hospital for, you can now go to a freestanding surgery center that's not part of the hospital. So it's a competitive environment, and we're going to respond to that competitive pressure to help people learn and to be actively engaged in their health care. I think it'll work.
Speaking of the competitive environment here, one of the other differences between Obamacare and Trump's plan that is potentially what they're kind of looking at right now, in Obamacare, current laws, including complex regulatory and licensing issues, they keep insurers state-bound. So everything is within Pennsylvania. Well, the Trump plan, or moving forward, if this goes through at all, it would remove some of those barriers so insurance companies could sell across state lines. So now we did have a Facebook viewer, Bruce, had asked if that moves across state lines, is his premiums, are they going to go up, or are they going to go down? Is it going to be more competitive as the Trump plan kind of seeks to move forward with?
I'm not an insurance expert. Generally speaking, when you're dealing with most purchasing systems and most economies, more consumer choice equals more competitive prices, generally speaking. I think that's the hope, that when you eliminate those geographic barriers to care and insurance, that you are going to get some more competition on price. You're going to have less of a captive market in the state by some insurers, and that would ultimately benefit the consumer. There are some trade-offs to that, which is why I don't know that either of us are the insurance experts to know what those trade-offs are, and whether we can have the same assurances that we have with the current conditions.
Yeah, I agree with you. I'm not an insurance expert either, but what I do know is that healthcare is a very local kind of market. And we have relationships between insurers and healthcare providers, and they're locally determined. When you go across state lines, we have to be very thoughtful that people are putting together networks of providers that are serving the immediate community where you're living. So I think there's a lot to do there. A promise that it's going to substantially lower premiums, totally untested. So I think we have to keep an open mind, but be careful that we not rush into that one.
We have another Facebook question that just went away. If I can find it and pull it up.
And the idea behind it was that with a lot of healthcare providers moving out away from the ACA in Pennsylvania, what do you think that will do for people's insurance coverage plans and their premiums?
Well, I'm not sure if I understood, Allie. I'm not seeing providers moving away from the Affordable Care Act. It is true, though, that insurance companies have been struggling in parts of the Affordable Care Act, particularly the marketplaces. Quite candidly, some of them have lost a lot of money. But on the other hand, we know that it's still a relatively young program. Medicare and Medicaid have been around since 1966, and they're both running better. They're not perfect, we know that real well. But they're running better than they did in the first 5 years of their existence. So we have some shakeouts to do to make sure insurance companies can earn a fair return on all that they spend building a product. But I say that throughout Pennsylvania, the fact that over 400,000 people enjoy insurance through these marketplaces, despite them being imperfect, is a really strong sign. That's 400,000 people in only a couple of years.
And I think we have another, this is more of a statement than a question, but maybe you guys can expand on this a little bit. Russell writes, I don't like the fact that my insurance makes me pay for a 3-month supply for them of my insulin for my wife, and her dogs keep changing. I don't see why I can't just go to a pharmacy and get it month by month. I know that has been a change here. A lot of people have to get that 3-month supply, or they can get month by month. Why does that change exist? And who does it benefit? Who does it hurt?
Well, to Russell, I would say he is witnessing steps to try to improve the efficiency of the delivery system. Healthcare is pretty famous for not being as efficient as many other industries. So the idea of a 3-month supply helps reduce transaction costs as one possible explanation. The other thing is that when you look at what's driving healthcare costs in America, there's no escaping the fact that prescription drugs are the fastest growing item in the healthcare delivery system. So insurance companies are taking steps to try to manage growth in pharmaceutical costs. It's an issue for hospitals too, because we buy lots of pharmaceutical products to treat patients. There's been tremendous growth in costs, twice the rate of healthcare growth costs overall. So that's another reason.
Well, and it actually wasn't me who texted the message under
Not this Russell.
Another Russell. I would say that, ironically, though, to his point, that the 90-day supply phenomenon, as Andy noted, was actually designed to help the consumer. Our system was inflexible beforehand, and you often had to do 15-day supplies just so that people didn't have extra meds laying around. And so now, what it starts to speak to, I think, is that we have to get away from the one-size-fit-all type of policies, that it's not a 90-day supply can be a godsend to someone on a maintenance drug who's going to have those chronic costs and who wants to have a lower unit cost for that prescription. Somebody like Russell, that 90-day supply that his insurance company's mandating because it's more efficient for them is wasteful and is costing him more money than he and his family would like to pay. And so we've got to find a way to kind of do what we used to call mass customization and serve everybody where they are for their specific needs, rather than kind of painting with a broad brush.
All right. And again, I think this is a good place to stop for a minute, because I think a lot of people walk into a pharmacy and cringe before they have to pay the bill. So that is something we will talk about as soon as we come back, as we continue our digital discussion on healthcare.
Patients and doctors should be making the big decisions, not government bureaucrats. Step by step. This is what our plan to repeal and replace Obamacare will do.
But the important thing is to make sure the people who are now covered are not left behind.
This is something that literally affects people's lives and their livelihoods, so it's not something we can rush.
They will have plans that today nobody has even thought about, because the market's going to enforce that with millions and millions of people wanting health care.
Let's all pay a fair share so that everyone can be covered.
This is the worst thing that ever happened to the American consumer.
If you're just joining us, we are live on Facebook for a digital discussion on healthcare, and we are taking your questions right below in our comment section and asking our panel of experts. Here we have Andy and Russ here about the questions that you have. We are getting the answers tonight, or at least trying to, and at least starting a conversation about these questions. And we were just chatting during the break about some of the most confusing things that people have to deal with. Not even finding the doctor, getting the procedure they need, but when they get the bill. A lot of this is very, very confusing. I mean, we've just talked about, both of us have gotten large bills that we were not expecting, with no breakdowns, no explanation of why did this cost this much. How does all that happen? So how does that happen? And how can that be changed? Is it different from insurance companies? I mean, where is all of this coming from?
It's happened because we as an industry haven't appreciated the need to explain it. For decades, those bills were handled almost in their entirety by insurance, if you had insurance. And most people had insurance. And so the whole system was designed around the relationship between a physician and a hospital and the insurance company, not the relationship with you. That's what's changing, because you're on the hook for more money. You are going to begin asking questions, and you need to start getting on the phone and calling the hospital and saying, or visiting. And my members are pledging to work with patients to help them understand why the bill is as big as it is, what insurance will cover, what your obligations are, and if your obligation is more than you can cover, they will work with you on a payment plan, for example. But it is important that you not hide or that you avoid the difficulty of it. If you step forward, they're going to be, and you can hold me accountable because I'm talking to my members about this all the time, getting better and better at simplifying the bills and making it easier to figure out what you owe.
It's almost that bedside manner when you get a bill, because I have no idea what this means. I know what I went there for. I have no idea what they did for me from point A to point B, and now I'm paying thousands for it.
And why can't you get ahead of that? Why can't, I know you are telling, you're kind of transparent. You kind of give people an option to understand what they're going in for. Why aren't more hospitals having that option for people? Like, why didn't we know that we were going to be paying a couple grand when we got out? Why are we getting sticker shock? You know, why isn't this something that we know that we can call and say, hey, I need this procedure, what's my ballpark? Why isn't that a standard?
It's a developing skill set. Like I said, St. Clair Hospital, for example, in Western Pennsylvania, has this price estimator tool on their website as one example. Crozier Keystone in the eastern half of the state has a price estimator tool. It'll spread. The word is spreading that these are effective, valued by patients and their families, and people have to test them. There are a lot of numbers that go into figuring out how big a healthcare bill is.
Is it beneficial for hospitals, though, to do that?
Absolutely, because first of all, it would build trust with their patients and their communities. Number two, it takes a lot of time to explain overly complicated bills.
Yeah.
And so, you know, the financial teams that are in healthcare these days, whether it's insurance companies or at physician offices or at skilled nursing facilities, financial people are a big part of the payroll. And if we can be better at this work, we can be more efficient, and we can eventually divert more resources to nurses and physicians and therapists.
But have you seen it impact your facility at all? Because you would think if people can go on there and find out this procedure is going to cost me $3,000 and I'm not going to die if I don't have it tomorrow, can I push it off? But if they go in thinking, oh, it might cost me $900, it might cost me $1,000, and then they get a $4,000 bill, I mean, that benefits the hospital in a long term, right? It's a large sum of money towards a procedure versus if they put it off, if they knew how much it was going to cost them.
Well, I'd say our hospitals are committed to providing top quality patient care. And they're judged by their communities, their boards who are made up of bankers and educators and lawyers and folks from the community. And they want to deliver over time high quality care. It's reported publicly, and it has to be affordable, and they have to be a long-term success financially. So scamming or the idea that
You're
people...
not scamming, but just people understanding how much they're going to be paying.
And that
they
is,
might not go in and do it. You know what I mean? If they know this is going to cost me $4,000, I might not do it. But if I go in thinking it's going to be, I can afford this, it can be too much, and then you get a whopper bill because you don't know how much it's going to cost,
well,
are people still going to go in and do it?
I think they're going to still need to get their health care. And here's how we can make sure people don't put off necessary health care because of the cost. We make sure that the Affordable Care Act repeal and replace bill that's on the table today leaves enough support, financial support for people that they don't face that decision. And that's the risk we're worried about, that the talk in Congress today is about stripping out hundreds of billions of dollars to support and make care more affordable. If you take all those supports out, people are going to delay their care, and it's care they shouldn't delay.
Are, at this point, hospitals losing money? Because like you said, a lot more of that burden is falling on to us instead of the insurance companies. And it's a lot easier for the insurance companies to pay than it is for the individual. So are hospitals losing money at this point?
Hospitals have seen a reduction in the amount of unpaid care they pick up. And that's thanks to the Affordable Care Act and the 1.1 million people who now have coverage that they didn't. So that's a good trend. It used to be over $1 billion a year in Pennsylvania that hospitals had to absorb. That's now under 900 million. So a big drop in just a couple of years.
Now, I know, kind of related to that question, I had this situation, and I can't be the only one. I got a bill, and it was crazy expensive. So I call, what can be done? Set up a payment plan, let's discuss this. And I was told that if I paid X amount up front, they could knock hundreds of dollars off my bill. Which made me question, well then, why was it this expensive in the first place? If you can knock off the money right now, why is it costing me so much up front? So how does that even happen?
And I'd say hospitals want to work with patients. And they also want to make sure that they are successful in having the resources that are necessary to provide care across the community. And so these are reasonable people. That's why having a conversation is always a good thing to do. We want insurance companies and we want the Affordable Care Act to do their job to make sure that you aren't facing excruciatingly tough financial decisions. But when you do, we do want to work with you to make it as affordable as possible.
I mean, my friends in hospital world, I've gotten a number of economic lessons from them over the past couple of months since the Affordable Care Act has come on board. And you would think that your experience would be, accurate, that, hey, if I'm looking at that $4,000 bill, I'm going to put it off. They really don't have a vested interest in playing that game because most health care is provided in an acute care setting is not it's not purely discretionary. There's some reason you're there in the first place. There would be a price for putting it off. And if they either intentionally or unintentionally, vis-a-vis how they show you a real sticker price versus what you're actually going to pay, you have a larger out-of-pocket than they thought and they don't collect, then they've provided a ton of care and put themselves in a worse place financially. So I actually finally got my head around, it is identically to our folks who are providing long-term and post-acute care that there's just no vested interest to kind of play that game where you're showing people the above the line price, not the actual bottom line cost. Because if you can't collect those dollars because someone says, well, I had 900, I don't have 4,000, you're out the 3,100, and that doesn't help you either.
Yeah.
So is there anything that you think lawmakers should know about? Because obviously this is an issue, like you said, we're talking about this. So is there anything that the lawmakers should know about in order to cut cost for the individual? Is there anything that should be added? Is there anything that should be voted on in regards to that? What could be done, at least from the hospital and the healthcare standpoint, that could help the people that come to you?
Well, number one, I think they have to make sure that the amount of money that's already being devoted to lowering the cost of care remains in the system. That's the first job for them. If they take all that money out, the kind of experience you had, your insurance, if you were getting any sort of support from the Affordable Care Act, your insurance is going to, without question, become much, much more expensive. And it's become much more expensive for low-income, older adults who are not quite Medicare eligible. So you're talking people who are 55 to 65. These are folks that under the American Health Care Act are at huge risk of seeing their premiums skyrocket as a result of this bill.
I do have a question here. So speaking of that term, we're talking about different age groups that are impacted by this directly. What about those who are under 26, who are on their parents' insurance, and they can't afford insurance when they get, right? So what do they do? What are their options?
Actually, here in Pennsylvania, many years ago, under Governor Ed Rendell, I believe, we took that 26-year-old mandate to 29 in Pennsylvania, state law. So Pennsylvania was actually a trailblazer in recognizing the role that a parent's coverage has in getting their young person from the formative years out of high school, and off into the world. And I'm not sure the specifics on that and if it requires the same level of care as the federal mandate, but there's a state-specific law already that exceeds the 26-year-old level here.
But that is only if both parties still live in the state, correct? If mom and dad live somewhere else or the child lives somewhere else, that is not the case.
So in any case, you turn either 30 or you turn 27, and you're no longer covered by your parents. If you can't afford health insurance, you can get help through the exchanges. And sometimes people make a decision that they don't want to buy coverage, and that's a problem. That's why the mandate is there. But for people who truly cannot afford it, all they have to do is fill out a little bit of paperwork to explain their income, and they can, depending on their income, get support for the cost of their premium, their monthly cost, plus some reduction in the cost of out-of-pocket expenses.
So why don't you think that people should have the choice to, if they want insurance, they pay for it. If they don't, then they don't? Why do people have to be forced to pay for it, and if they don't, they pay $800 on their taxes?
Right.
I mean, isn't it like when the seatbelt law went in? Some people were like, you can't tell me to wear my seatbelt. Yeah. So why do you think that people should be told that you have to? I mean, they go on a whim that I'm not going to get hurt, right? So
my position, the hospital industry's position, is that we are neutral between whether you use a mandate or you create financial incentives that make it more attractive to get insurance. So let's say you're right. Why do we have to mandate, or why do we even have to offer these incentives? Because the way insurance works, if healthy people aren't in the insurance pool as well as the sick people, insurance companies pay out more in benefits than they collect in premiums, and they go out of business and they leave. So we need healthy people who don't need health care right now to be insured so that the whole thing works together.
a lot of people would argue that that's not fair if they're healthy.
And what is also not fair is when people are healthy and they suddenly get sick, but they don't have insurance and they want care. And we are obligated as hospitals.
But don't they still get a bill? I mean, won't they still have to pay the fees that they go through for health care, or do they not get served?
Oh, they will get bills for care, but many people simply can't afford to pay a $20,000 bill. We try to work with patients, and if they cooperate with us, and we can work out payment plans, but even that can be too much. And then we have to write off the cost. So insurance is really part of an agreement amongst all of us. Yes, you are healthy. Why should you have to be a part of it? It's roughly analogous to the idea that we are required to have auto insurance. So we're required to have, under this plan, we should have all should have health insurance, because you never know when you're going to need the help.
Do you think there will be a day where I can pick my insurance? Meaning, if I'm healthy, my employer offers these 3 different tiers. All are, of course, more than I would like to pay. So do you think there will be a day where I can say, you know what, this is how much I'm going to pay? And I can get the coverage for that because I am healthy. So that way, if I don't have the coverage later on, it's my problem. Because I decided I was going to start at a lower premium there.
I'd say the system that we have today offers lots of choice. I mentioned the metal plans, platinum all the way down to copper, I think. And so there's choice there, and you can be in the individual marketplace. You can buy insurance through your employer. And you can, there are, the skinniest plan on the exchange today is relatively lower cost. What we worry about, and this is an issue that's in the plan being debated right now, is that if you have so little coverage in your plan to make it affordable, that it's almost worthless, that it would only be valuable to you if you had the most catastrophic incident. And that's not how you ultimately go through the delivery system. Those catastrophic rare events aren't what you face. Most likely you face procedures, a need for something that's not catastrophically expensive. Having decent insurance is really important to make sure you're not on the hook for too much.
Yeah, and I would say we're going to have to get to that place. I mean, our folks would be covered by long-term care insurance, which isn't really a properly functioning market in this country or the Commonwealth right now. And it's because the whole definition of insurance that Andy laid out, our automobile example, where we all got to have it to drive. Therefore, it costs you, depending on where you live, a couple thousand a year and your age and your record. And you can get a reasonable plan with, let's say, a $500 or $1,000 deductible, doesn't bankrupt you out of pocket, you have an accident, and you're back in a reliable vehicle moving forward. That works because all of us are required to have it. On the long-term care side, the only people who purchase it are people who are already close enough to that catastrophic need that the premiums can't keep pace with the costs. And therefore, that's why you see insurers coming with these year-over-year catastrophic increases, asking the insurance commissioner at a state to give them a 40–50% increase in a premium, having a senior couple who felt like they were doing the right thing when they turned 60 and bought this inflationary policy at $1,000 each for a year with an inflation rider, and now when they're 68, it's $7,000 each for the year, and they're wondering, how is this a good deal? And it comes back to us needing to get to a place where we have more people with that coverage, more than the 8 to 10% that pick it up right now.
Now, do you think, because this is another topic that has been brought up, something like a healthcare savings account or a flexible savings account can help add and contribute to this? Or does that even not on the hospital and care side even count? That's just an insurance side thing.
No, it's it's a very important tool. I participate in a health savings account, for example. I think what we worry about is the idea that everybody can be successful with a health savings account, that you can have enough of your own money to put into it to build up enough resource to pay that $4,000 bill. Lots of people do not have even a few $100s to put into a health savings account. So if their employer isn't financing it, we can't be sure that people can take care of it themselves. That's why the Affordable Care Act has lots of dollars in there to help people with relatively low and middle income be able to afford insurance.
So what is the difference, though, between the health care savings account and the flexible savings account? Is there a difference? Because I know it's spending. Sorry, flexible spending account.
Yes.
Yes?
There is a difference, yes. A flexible spending account is a pre-tax dollar that you get to use for healthcare costs. And it's your dollars that are put in there for other out-of-pocket expenses, prescription drugs, eyeglasses are big ones that families will use with pre-tax dollars. Whereas that health care savings account has to be used for your health care coverage. There's some rules around you keeping the investment income if you can put the type of dollars in that Andy noted. I have one as well for my family, but it's heavily supported by my wife's employer under whom we have our coverage, because they have an incentive to do that, and then it puts the incentive on us to use healthcare services in the insurer's mind more responsibly and not take it for granted and have it there when we need it, but not superfluously purchase it just because my knee's been bugging me. Let me go get an MRI to see what it looks like.
Yeah. So who are the people, if you can kind of give a broad example of the people who you think should have it and the people who you think should not have it? HSA.
Well, I think anybody that wants to save, because these are healthcare savings accounts, and money you don't use in a year rolls over and you can keep it all the way until your retirement. So it's a savings vehicle. So anybody who has the means to save, it can be a very good plan. And it does help spread the risk a little bit between you and the insurance. So I think it's an individual decision for folks. Right. What worries us is when the conversation in Washington turns to, we don't need all these Affordable Care Act programs. Health savings accounts are all we need. But they're not, because you have to either have an employer that will finance them, put all that money into the account, or you have the means to do it. And lots and lots of Pennsylvanians don't have even $300 to put down into a health account. Right?
It's at this point, it almost seems like you need to meet with a financial advisor before you even sign up for health care.
Excellent point, Jackie.
Yeah.
Excellent point.
Speaking of rising costs and things, pharmaceuticals and prescription drugs, that keeps going up, it seems like. What do you think the outlook is on this, and what do you think it could be, mean for people here in Pennsylvania for the rising costs in pharmaceuticals?
Well, it's a $300 billion spend in this nation, $309 billion on pharmaceuticals. There are no easy answers because pharmaceutical products are a critically important part of helping us stay healthy and get healthy. What we would say is that we probably need more transparency in how prices are set, just like we are trying to be transparent with hospital pricing, so too does the pharmaceutical industry. Second, you mentioned earlier, Jackie, the idea that we're always buying generic drugs. Where are the brand name drugs? Well, actually, there's evidence that people trying to put new generic drugs, less costly drugs on the market face an awful lot of barriers to doing so. And I won't bore you or your viewers with it, but lots and lots of barriers, legal hassles that make it hard to get those lower priced alternatives on the market. I think there's work to do there to simplify that process of moving from brand to generic. It's important to the hospital community because we do buy so many pharmaceuticals, and I think we have to get on top of it as one of our highest priorities.
Now, Russ, what do you think will happen with PACE? That's a program for the reduced cost for people that are 65 and up, right? For prescription drugs and pharmaceuticals. If the ACA is repealed or replaced, where do you see that ending up?
Actually, the state PACE program is paid for with our state lottery dollars primarily, and there's some wraparound with the state Medicaid program, but I don't think we'll see the impact. PACE will still be intact, and our elders in Pennsylvania will still have access to a very robust level of pharmaceutical coverage through the PACE program, and it's a phenomenal benefit to them through our lottery.
Good. I'm sure that's really good for a lot of people to hear that maybe were worried what would happen with their prescription discount coverage there too.
So as we stand right now, we're all kind of in limbo. We don't know what is going to happen next. We have not seen really anything set in stone that is exactly saying this is what we're doing or this is what we want to do. It's kind of a back and forth. So to kind of end our discussion here, I would like if you two could kind of give your input to the lawmakers on what you think would put Pennsylvania in the best place if we were to change something or stay with what we have.
Well, first, do no harm. 1.1 million people enjoy coverage thanks to the Affordable Care Act. So keep that number where it is, and let's keep growing. So that's number one. Number two, recognize that Medicaid, which is part of the discussion, is a huge part of providing health care to older Pennsylvanians, disabled Pennsylvanians, children. And 2.8 million Pennsylvanians enjoy health care coverage thanks to Medicaid. And we have to protect that. That's a huge priority. So those are my two top.
Russ?
And I would actually add on to that to note that I'd like them to recognize the impact that regulations and regulatory costs have on providers. There are two sides of the equation. There, what you get paid for a service, and then what it costs you to provide that. And when you have to have maybe 3 people doing a job that one person could do because of a regulatory requirement. An example from my world is we have to have a nutritionist on staff all 3 shifts in a nursing facility, when a single nutritionist could make the menu for the residents throughout the day, we're paying 3 people and 3 benefit packages when we would only need 1. That type of mandate, when we're in a refined resource system, uses dollars that could be used for care. The other piece is, and it's something that's near and dear to our heart at the Pennsylvania Healthcare Association, the impact that our tort climate here in Pennsylvania has had on businesses and providers. We've got an out-of-control tort climate here in Pennsylvania where we feel like our backs are against the wall to predatory travelers.
Can you break that down a little bit, Russ, for anyone at tort climate, what maybe they don't understand?
Sure. Healthcare providers are getting sued nonstop. I'm not going to, well, I may use it because we don't have much time left. The proverbial ambulance chaser mindset, where I'll put an ad out there, I'll throw an ad in the paper, call me if you think this something bad's happened to you, and I'll get money for you. And providers are losing hundreds of thousands, if not hundreds of millions of dollars a year. Here in Pennsylvania, the Medicaid program alone on long-term care is spending over $100 million in tort-related defense costs. That's $100 million that could be back at the bedside caring for vulnerable Pennsylvanians, but it's almost a cottage industry with lawsuits that are being filed against providers just because we're human beings, as Andy noted earlier. None of us have the same outcome for care. And sometimes those outcomes aren't what people were hoping, and suits are filed. So those are kind of the 2 big issues that I would say they should pay attention to.
And I would say with just the 2 of them sitting here, that is 4 issues. That is a lot for people to handle, and I think that is kind of across the board. If you were to ask what both of our biggest issues were, it would probably be different from those. And that's what happens when it comes to healthcare. There's a lot of discussion going on, a lot of issues.
It's been ongoing for years.
And why right now we don't really have a perfect solution. I think it's all safe to say that at that point. Well, we want to thank you guys so much for coming out here tonight and having this continuing discussion about healthcare. We really appreciate your input. We appreciate you answering our viewer questions, and we appreciate our viewers leaving the comments.
Yeah, and you guys can always watch this back. It's on our Facebook Live platform right now, but you can go back to Facebook and rewatch the entire discussion. So I want to thank you, Andy Carter, Russell McDade, for being with us tonight. Thank you guys so much. We hope you learned something from our wonderful panel of experts. Thank you, gentlemen.
Thank you.
All right, thanks so much.